Bismillahirrahmanirrahim. I'm going to discuss the RCOG guideline about blood transfusion in obstetric. This guideline was published in May 2015. This is the executive summary of recommendation. We will discuss this summary one by one. Coming towards the purpose and scope of this guideline. Okay, in the public purpose and scope of this guideline, some important things are discussed. So the first thing is what is the importance of the blood transfusion in obstetric. That is written: obstetric conditions associated with the need for blood transfusion may lead to morbidity and mortality if not managed correctly. So that is the main importance of the blood transfusion. Okay, and what are the important issues in the blood transfusion? So this answer is written here. The increasing important issues in the blood transfusion are adverse events related with the transfusion, including potential infection, potential transmission of prions, rising cost, and possible future problems of availability. So these are four main issues. First of all, potential infection transmission, potential transmission of prions. Prions are in fact the small particle, infectious particles, or any other particles. And rising cost is another problem, and future problem of availability is the main problem. Now coming toward the introduction and background epidemiology, so the main thing which is written is that how much is the risk of maternal mortality due to obstetric hemorrhage. That is written here. Obstetric hemorrhage remains a major cause of the maternal mortality in the UK and now third leading cause of direct maternal death. Okay, first leading cause is VTE, venous thromboembolism, second is hypertensive disorder, and third is hemorrhage. I'm talking about the direct maternal death. Okay, and it accounts for 10% of all the direct maternal death. Okay, this does not represent a significant increase in mortality as deaths have decreased overall, and substantial management continue to be a significant contributor to mortality from hemorrhage, and it is estimated there are more than 4,000 cases of severe hemorrhage each year in the UK. The majority of these women will need blood transfusion. Okay, now what are the risks of blood transfusion? Those are written here. Blood transfusion may be life-saving saving procedure, but it is not without risk. Recipient may rarely develop transfusion transmitted infection or suffer immunological sequelae such as red cell immunization. Okay, and the major risk, however, of the blood transfusion is of patient receiving an incorrect blood component and strict adherence to the correct sampling, cross-matching, and administration procedure is there of paramount importance in any emergency. Identification and assessment of evidence, nothing special is written here. How can the risk of blood transfusion be reduced? These are very important. First of all, point 4.1 is that optimization of hemoglobin in antenatal period. If you have optimized the hemoglobin in antenatal period, that in that way we can reduce the risk of the blood transfusion. Okay, we have to do correct diagnosis, and as I have told you in the previous guideline of anemia in pregnancy, that we have the definition of anemia in different trimester depending upon HB level. Anemia in pregnancy is defined as first trimester hemoglobin less than 110 gram per liter, second and third trimester less than HB less than 105 gram per liter, postpartum HB less than 100 gram per liter, in line with the BCSH guideline. For normocytic or microcytic anemia, a trial of oral iron therapy should be considered as a first step, and the further test should be undertaken if there is no demonstrable rise in HB at 2 weeks and compliance has been checked. Okay, if this microcytic and hypochromic anemia, microcytic and normochromic anemia, then in that case we can give the patient oral iron, and HB level is checked after 2 weeks. So the trial of oral iron is given. And the screening is very important. Pregnant women should be screened for anemia at booking and at 28 weeks. Women with a multiple pregnancy should have additional full blood count done at 20 to 24 weeks of gestation. Okay. Now coming to the definition of the anemia, the BCSH, British Committee for Standard in Hematology, has defined what it considers to be adequate HB level at different stages of pregnancy. The intrapartum and postpartum threshold for HB are derived from the World Health Organization, with a modification suggested by the US Center for Disease Control and Prevention because of plasma expansion seen in the second trimester. Okay. If HB is less than 110 gram per liter in the first trimester or less than 105 gram per liter in the second and third trimester, consider hematinic deficiency once hemoglobinopathies have been excluded. The same thing is written here. And how diagnosis of iron deficiency is done? Iron deficiency can be difficult to diagnose. The signs and symptoms are generally non-specific. Serum ferritin is the most useful test for diagnosing iron deficiency, but it is an acute phase reactant, and other laboratory parameters have their limitations. Anemia not due to hematinic deficiency, for example, hemoglobinopathies and bone marrow failure, should be managed by transfusion where appropriate in conjunction with a hematologist. Okay, so iron deficiency should be corrected by giving oral iron if it is within the acceptable range or if the patient is not symptomatic. But in case of the other hemoglobinopathies in which the cause is not due to iron deficiency, then in conjunction with the hematologist we can transfuse the blood to them. Now another thing, when is the screening done? In line with a NICE, screening for anemia should be offered at booking at a date with additional full blood count at 20 to 24 for the women with the multiple pregnancies. Now management and treatment are very important. How we do management and treatment of these women? It's written that oral iron should be offered first line treatment for the iron deficiency. Okay, so that is oral iron. When is parenteral iron given? Parenteral iron is indicated when the oral iron is not tolerated or absorbed, or the patient is in doubt, or if the woman is approaching term, or if there is insufficient time for oral supplementations to be effective. Okay, first of all, if the patient is not can't tolerate oral iron. Secondly, if the patient is approaching term, and thirdly, if there is insufficient iron time for the oral iron to be effective. And women should receive information on improvement of the dietary iron and factor affecting absorption of the dietary iron. The role of the recombinant, what is the role of recombinant human erythropoietin? The role of recombinant human erythropoietin for the non-end stage renal anemia is still to be established, and it should only be used in context of a controlled clinical trial on the expert advice of hematologists. Okay, and active management of the third stage of the labor is recommended to minimize the blood loss, and women at the risk of hemorrhage should be advised to deliver in the hospital. So these are few important things. Now something about the iron and folic acid supplements. A meta-analysis of randomized controlled trial on antenatal use of iron with or without folic acid showed a 50% reduction in the anemia in the third trimester at delivery. Okay, so if we used oral iron antenatally, that results in 50% of reduction in the risk of anemia in the third trimester. Okay, so what is the main advantage of the iron? That is written here. A Cochrane review of the studies comparing iron supplementations with no iron or placebo found that the iron supplementation decreased the incidence of the low birth weight baby and prevented maternal anemia and iron deficiency anemia. Okay, so not only in the mother it reduces the risk of maternal anemia, but also it results in prevention of the risk of the low birth weight babies. A second Cochrane review comparing the intermittent versus daily iron supplementation showed that intermittent supplementation produced a similar risk of anemia at term, prematurity, and low birth weight, but was associated with fewer side effects. Okay, so intermittent supplementation have similar outcomes in reducing prematurity, low birth weight, but it has associated with a fewer side effects. So in that case, that is preferred. Parenteral iron therapy is written. Parenteral therapy offer a short duration of treatment and a quicker response than the oral therapy. It is, however, more expensive, invasive and expensive to administer, and several allergic reactions are possible with all iron preparation, and intravenous iron products should be administered when the staff are trained to evaluate and manage anaphylactic or anaphylactide reactions, as well as resuscitation facilities are immediately available. Now coming toward the dietary sources. Okay, it's written that the rich sources of the dietary iron are red meat, fish, poultry, and these provides heme iron that is more readily absorbed, more easily absorbed than the non-heme iron, but the later form the vast majority of iron taken through the diet, and vitamin C enhances the absorption of the non-heme iron, whereas the tea and coffee inhibit iron absorption from the food. Recombinant human erythropoietin is written that is most widely used in anemia of the end-stage renal disease. Recombinant human erythropoietin has been used both antenatally and postpartum in the patient without end-stage renal disease, without any maternal, fetal, or neonatal adverse effects, and its use in the clinical practice for the non-end-stage renal anemia is still to be established and should only be used in context of controlled clinical trial and or under hematologist advice. Okay, so it should not be used in each and every case. Okay, now the third stage of the labor active management. About this, something is written. Clear evidence from the randomized control trials support the active management of the third stage of the labor as a method of decreasing postpartum blood loss. Now, hospitalization for delivery, that is written. Maternal death from the hemorrhage in the UK have fallen over the years, and one contributor is considered to be hospitalization for the delivery of the woman at higher risk of the hemorrhage, older women and grand multipara, and those with a preeclampsia. Okay, now the general principles of transfusion. Consent for the blood transfusion is very important, that the valid consent should be obtained where possible prior to administering blood transfusion, and in emergency where it is not feasible to get consent, information on the blood transfusion should be provided retrospectively. The reason for the transfusion and note of the consent discussion should be documented in the patient case notes. Okay, now something is written here about the valid consent. The Advisory Committee on the Safety of the Blood Transfusion Tissues and Organ, SAPTO, following a consultation exercise looking at the consent for the blood transfusion, recommended that the valid consent for the blood transfusion should be obtained wherever possible before administering a transfusion. While this does not entail the specific written consent, valid consent does not require the provision of information to the patient. Does require the provision of information to the patient on the risk and benefit together with the alternatives available with a clear documentation in the clinical records. Okay, and what to do in case of the patient refusal, where transfusion of all or specific blood transfusion is refused or an advance directive exists, this should be documented in patient clinical notes and communicated with the relevant health professionals. Emergency. So what we do in case of the emergency blood transfusion, patient who require emergency blood transfusion may not be able to give valid consent prior to transfusion. Transfusion should not be delayed, but attempts should be made to provide information retrospectively. Patient information leaflet and blood transfusion are available in the UK. Okay, and another thing is that there should be clear documentation of each and everything. The decision process leading to transfusion, including the indication for transfusion and obtaining valid consent, should be documented in the patient's clinical record. Now, requirement for the blood group and screen samples and the cross matching. All the women should have the blood group and antibody status checked at booking and at 28 weeks of gestation. Group and screen samples used for proving of the blood in pregnancy should be less than 3 days old. Okay, and what should be specifically done in case of the high risk pregnant patients who may need the emergency transfusion? In the women at the high risk of emergency transfusion, for example, placenta previa, and with no clinically significant antibody, group and screen samples should be sent once a week to exclude or identify any new antibody formation and to keep the blood available if necessary. Close liaison with the hospital transfusion laboratory is essential. Okay, now locally agreed protocol that is written here in this line. Women should have a group and screen sample taken in line with clear locally agreed protocol for provision of the blood. Okay, now in the another small paragraph, maternal red cell antibodies are written. Maternal red cell antibodies are relatively common. These can cause hemolytic disease of the fetus and newborn and will have implication for the selection of the blood for transfusion in the mother to avoid the risk of hemolytic transfusion reaction. Accordingly, the blood group and antibody status of the mother should be tested at the booking and at 28 weeks of gestation. This is the case in those in which there is suspicion of maternal red cell antibodies formation. Now, maternal antibody level at booking and importance for further testing that is written here. When the red cell antibodies are detected in the booking, further testing of the maternal blood should be undertaken to determine specificity and the level of the antibody or antibodies and to assess the likelihood of the hemolytic disease of the fetus and newborn, with early referral to the specialist fetal medicine unit depending on the nature of the antibody, the level of the previous history, and further detailed assessment of the detail is written in the another guideline. Okay, so why group and safe samples should be less than 3 days old, that is written here. Transfusion or pregnancy may stimulate the production of unexpected antibodies against the red cell antigen through either a primary or secondary immune response. To ensure that the specimen used for compatibility testing is representative of a patient's current immune status, serological studies should be performed using blood collected no more than 3 days in advance of the actual transfusion when the patient has been transfused or pregnant within the preceding 3 months. Now something written about the high risk patient needing transfusion. Okay, it's written that a formal deviation to 3 days rule may be used in the pregnant woman with a no clinically significant alloantibodies who require blood standing for potential obstetric emergency, for example placenta previa, with a sample sent once a week to the transfusion laboratory for testing. Fetal hemorrhage constitutes a smaller stimulus than transfusion because the number of the foreign antigens is limited, and in many pregnancies, the volume of the red cell transfer from the fetus to mother is too small to stimulate the primary response. Now, is there any locally agreed protocol? The majority of the laboratory in the UK now use the automated testing for the blood grouping and antibody testing with advanced information technology system for documentation and reporting of the results. Okay, and the hospital transfusion laboratory can readily provide red cells that are ABO and RCOG compatible using electronic issue with no cross matching needed, provided that the patient does not have any antibodies and there are robust automated system in place for antibody testing and identification of the patient. In this setting, since the blood can be readily issued, there is no need to reserve unit for individual cases. Where electronic issues is not available, the locally agreed maximum surgical blood ordering schedule should be used to decide how many red cells unit should be reserved and available for particular cases based on the obstetric diagnosis. In patient with the red cell antibodies, cross match between the patient's blood and the red cell units to be transfused is essential to ensure the compatibility. Now, what is written in this paragraph? What to do if we do offset serology and what needs to be done in this case. It should be it should be borne in mind that many hospitals send antenatal serology offsite for economies of the scale. If the hospital send antenatal serology sample for testing offsite, it is advised that Results of the blood grouping and antibody screening should be made readily available for the local units. Okay, and if the laboratory provision is offsite, there should be robust system in place for the local arrangement for the provision of the blood and components if required, taking into account transport time and whether or not woman has red cell antibodies. Okay, and need for sending second sample. Unless secure electronic patient identification in place, a second sample should be requested for confirmation of the ABU group of the first time patient prior to transfusion, where this does not impede the delivery of the urgent red cells or other components. Now, blood products or specification in the pregnancy and puerperium. ABO or HDK compatible blood cells should be transfused. And what to do when clinically significant red cell antibodies are present? If clinically significant red cell antibodies are present, then the blood negative for the relevant antigen should be cross-matched before transfusion. Close liaison with the transfusion laboratory is essential to avoid the delay in the transfusion and the life-threatening hemorrhage. Okay, and the third important thing is that CMV seronegative red cells and platelet components should be provided for the electronic transfusions during pregnancies. Okay, and in the detail, these all things are written that blood should be group compatible, and secondly, if we have emergency, then we should use negative blood, and the CMV negative serology should be there, and CMV seronegative blood should be used. So what are the strategies to minimize the use of the bank blood? Is there any rule for pre-operative, pre-delivery autologous blood deposit? Pre-delivery autologous blood deposit is not recommended. Okay. And is there any rule for intraoperative cell salvage? Yes, there is a great role of it. When is it indicated? Cell salvage is recommended for the patient where anticipated blood loss is great enough to induce anemia or expected to exceed 20% of estimated blood loss. Do we need consent? Yes, consent should be obtained for intraoperative cell salvage where possible, and its use in obstetric patient should be subject to audit and monitoring. Another thing is that who can perform cell salvage? Cell salvage should only be performed by multidisciplinary team who have regular experience of intraoperative cell salvage. Okay, and the role of immunoglobulin administration, that is important, where intraoperative cell salvage during cesarean section in RHD negative, previously non-sensitized women, and where cord blood group is confirmed as RHD positive, a minimum dose of 1500 international unit anti-D immunoglobulin should be administered following the reinfusion of the salvaged red cells. Now, checking maternal blood samples. A maternal blood sample should be taken for estimation of fetal-maternal hemorrhage 30 to 40 minutes after reinfusion in case more anti-D is indicated. Now, management of obstetric hemorrhage with blood components. There should be a clear local protocol on how to manage major obstetric hemorrhage. The protocol should be updated annually and practiced in the skill drill to inform and train relevant personnels. Okay, and in this whole paragraph, the significance of the local protocol is written. And in the next paragraph, there is written importance of updating protocol plus training. Now, are there mechanical strategies that can be employed? Clinicians should familiarize themselves with the mechanical strategies that can be employed to reduce the postpartum blood loss. And what blood components can be used for obstetric hemorrhage? When should red cell be used? Okay, indication for red cell transfusion is written that there is no firm criteria for initiating red cell transfusion. The decision to provide blood transfusion should be made on the clinical and hematological ground. Okay, and negative blood group in emergency situation, that is written here. In extreme emergency situation and when the blood group is unknown, Group ORH negative blood cells should be given, although they may be incompatible for patient with irregular antibodies, but as this is emergency situation, so we can use RH negative. Now the importance of satellite blood fridge is written. Staff working in obstetric unit should be aware of the location of the satellite blood fridge where available and should ensure that access is possible for the blood collection. Indication for blood transfusion is written. I think we should read this paragraph. It's written that there is no firm criteria for initiating red cell transfusion. The decision to perform blood transfusion should be made on both clinical and hematological ground. And blood transfusion is almost always required when HB is less than 60 gram per liter and is rarely required when HB is greater than 100 gram per liter. Okay, so if we talk about the HB level, if HB is less than 6, then we should give blood transfusion. If HB is more than 10, we shouldn't give blood transfusion. But it should be remembered that the patient with acute hemorrhage can have normal HB. His clinical evaluation of patient in this situation is extremely important. So not only the HB level, but the clinical evaluation of the patient is also very important. Okay, and negative blood group in emergency situation, the importance of that is written. Between October 2006 and September 2010, the rapid response report from NPSA is in fact National Patient Safety Agency, reported 11 deaths and 83 incidents where the patient suffered harm as a result of delay in the provision of the blood. One of the reasons for this delay in the blood transfusion during the life-threatening bleeding episode was a lack of understanding concerning the term cross-match, whereby the clinicians frequently request the cross-match blood without realizing that this could take time, which is not optimal in an emergency. Okay, thus in the event of the life-threatening hemorrhage, even if the woman has RBC low antibodies, the transfusion of group O RH negative blood cells or group specific red cells must not be delayed. Okay, and satellite blood fridge should be available in order to facilitate the immediate provision of the uncross match or red cells for the patients who suffered massive hemorrhage. Some National Health Service organizations have introduced satellite blood fridge in the different clinical areas, and medical staff working in these organizations and who are involved in the management of the major bleeding should be aware of the fridge location and should ensure that access is possible for the blood collection. Okay, then in what circumstances should fresh frozen plasma and cryopreservative be used? Fresh frozen plasma at the dose of 12 to 15 ml per kg should be administered every 6 units of red cells. Okay, so 6 units of red cells and FFP at the rate of 12 to 15 ml. Okay, of red cells during major obstetric hemorrhage. Subsequent FFP transfusion should be guided by the results of the clotting test if they are available in timely manner, aiming to maintain prothrombin and activated partial thromboblastin ratio at least less than 1.5 into norm. And it is essential that regular blood counts, full blood counts, and coagulation screening, PT, APTT, fibrinogen are performed during the bleeding episodes. Cryoprecipitates at the standard dose of 2-5 units pool should be administered early in the major obstetric hemorrhage, and subsequent cryoprecipitate transfusion should be guided by the fresh frozen plasma, aiming to keep the level above 1.5 gram. Okay, so how much FFP should be given? FFP should be given, cryoprecipitate should be given to the level so that we can maintain fibrinogen level above 1.5. The FFP and cryoprecipitate should ideally be of the same group as a recipient. Okay, if unavailable, FFP of a different APO is acceptable, providing that it does not have high titer of anti-D and anti-B. And no anti-D prophylaxis is required if RH negative women receive RH positive FFP or cryoprecipitate. Okay. And what is the role of FFP? Observation studies in military combat casualties have suggested that early administration of FFP and high ratio improve the clinical outcome of the trauma bleeding patients. However, due to lack of the randomized control trial, the optimum FFP to RBC ratio for the management of the major bleeding remains unknown. Further, no studies have evaluated the optimum dose of FFP during the major bleeding, and further evidence become available until we recommend that FFP at the dose of 12 to 15 ml per kg should be administered for every 6 units red cells during major hemorrhage. Okay, and so for every 6 units of blood transfusion, FFP at the dose of 12 to 15 ml per kg should be given. We should remember this point. And subsequent FFP transfusion should be guided by the results of the clotting test if they are available in a timely manner, aiming to maintain PT-APTT ratio less than 1.5 into normal. Okay, a PT-APTT ratio should be less than 1.5 into normal. And if it's more than 1.5 into normal, we should transfuse more FFPs. Once FFPs have been ordered, it takes at least 30 minutes to thaw an issue. During this time, resuscitation should be continued with the volume expanding fluid or red cells as appropriate. Okay, and it's written that transfusion transmitted infection, that is written here, that it should be borne in mind that at present in UK, most of the units of the FFP, as in case with the red cells, platelets, precipitators are not virally inactivated, and then transfusion with these products offer a small risk of transfusion transmitted infection. Okay, blood tests to be done. A full blood count play an important role in guiding the red cell and platelet transfusion during the major hemorrhage, while PT-APTT fibrinogen level should be used to guide FFP and cryoprecipitate transfusion respectively. Fibrinogen level is written. Observation studies have indicated that fibrinogen less than 2.9 liter is associated with increased risk of the PPH, and one study showed that decrease in fibrinogen level was an early predictor of the PPH, and that the risk of the PPH was 2.63 fold higher for each 1 gram per liter decrease in fibrinogen. When platelets should be used? Okay, aim to maintain the platelets count above 50 into 10 raised to power 9 in the acutely bleeding patients. That is very important. And a platelet transfusion figure of 75 into 10 raised to power 9 is recommended to provide the margin of the safety. Okay, so the aim should be to keep it more than 50, and transfusion trigger of 75 into 10 raised to power 9 is recommended to provide margin of safety, and the patient should ideally be group compatible. For FFP and cryoprecipitate, as we have studied that it's not necessary to be group compatible, but platelets should be group compatible. Ideally, that FFP and cryoprecipitate should be of the same group, but it's not necessary. But in case of platelet, it is necessary. An RHD negative woman should receive RHD negative platelets. Same thing is written in detail. Now coming toward, is there any role for near patient testing of the coagulation? Centers are using thromboelastography, hemodynamics, Braintree, Masucci, and Massachusetts, or rotation thromboelastometry, ROTEM, for guiding blood transfusion during the major obstetric hemorrhage, must ensure that their transfusion algorithm protocol has been validated and that quality assurance measures are followed. Pharmacological strategies for management of the major obstetric hemorrhage. Is there any role of recombinant factor 7A therapy? The role of recombinant factor 7A may be considered for treatment for the life-threatening PPH, but should not delay or be considered as a substitute for life-saving procedure as embolization or surgery or transfer to the referral centers. And what is the role of recombinant factor 7A in PPH? There has been no randomized controlled trials to assess the efficacy of recombinant factor 7A in PPH, and a number of the case series and the national registries have indicated that administration of recombinant factor 7A during PPH might reduce the risk of might reduce bleeding and transfusion requirement. However, none of these reports were powered to assess the safety of recombinant factor 7A. Moreover, these studies vary significantly with respect to the timing and dosing of recombinant factor 7A and the incidence of thrombotic complication. The review of this 272 women with the PPH who had received recombinant factor 7A was reported to be 2.5%. So in 2.5% cases, there were thrombotic complications. There is no evidence to support the role of prophylactic use of recombinant factor 7A to reduce the blood loss for cesarean section. Okay, is there any role for fibrinogen concentrate therapy? Okay, fibrinogen concentrate is not licensed in UK for the management of the acquired blood bleeding disorder. Thus, its use in PPH should be considered only in context of the clinical trial. Okay. Now, what are the major advantages of the fibrinogen concentrate? The main advantages of the fibrinogen concentrate compared with the cryoprecipitates are faster recognition, ease of the use, and not requiring thawing or the ABO compatibility. No randomized controlled trials or prospective studies have assessed the efficacy of the fibrinogen concentrate on obstetric hemorrhage, and one retrospective study compared the clinical outcome of the 20 and 14 women with the PPH who had received fibrinogen concentrate and cryoprecipitate respectively, and there was no significant difference between the two groups with regard to the estimated blood loss, RBC transfusion, FFP transfusion, and high dependency units or intensive therapy units. Now, is there any role of antifibrinolytics? For those scientists not participating in the clinical trial, consideration should be given to using tranexamic acid during the major obstetric hemorrhage. Okay, what is the main advantage of the fibrinogen concentrate? The main antifibrinolytic agents used in UK is tranexamic acid. Tranexamic acid is a synthetic derivative of amino acid lysine that reversibly binds to the lysine binding sites of the plasminogen molecules. In doing so, it prevents the activation of the plasminogen to plasmin, leading to inhibition of fibrinolysis. And the CRASH 2 study showed that tranexamic acid reduces the mortality in bleeding trauma patients without an increase in the rate of the venous thromboembolism. Is there any role of antifibrinolytic in obstetric study? In obstetric settings, several randomized control trials have compared the use of tranexamic acid with placebo no treatment. Apart from one study, all other were performed in the women undergoing cesarean section. The overall conclusion was that tranexamic acid significantly reduces the blood loss. However, none of these trials was significantly powered to assess the mortality rates and the safety of tranexamic acid. Further, they were heterogeneous in their definition of the PPH and the dosing of tranexamic acid and the timing when the blood loss was measured. Okay, so the mortality, no data exists, but the overall study was that tranexamic acid significantly reduced the blood loss, so we should use this tranexamic acid in case of cesarean section on routine basis. How should intraoperative anemia be managed? In addition to the major hemorrhage guideline, obstetric units should have guidelines on the criteria for the blood cell transfusion in anemic women who are not actively bleeding. If HB is less than 70 grams per liter in the labor or an immediate postpartum period, the decision to transfuse should be made according to the individual medical history and the symptoms. Transfusion will be indicated in the woman with the continued bleeding or at risk of the further bleeding, imminent cardiac compromise, or significant symptoms requiring urgent corrections. So these are basically the indications for transfusion. And how should women with the postpartum anemia be managed in the postnatal period? Okay, if HB is less than 70 grams per liter in the postnatal period where there is no ongoing or threat of bleeding, the decision to transfuse should be made on informed individual basis. Okay, so in case of pregnancy, if HB is less than 70, we should consider the transfusion, but in postnatal period, the decision should be made on individual basis. So, audit indicate that high proportion of blood transfusion administered in the postpartum period may be inappropriate with underutilization of the iron supplements, and prompt recognition of the iron deficiency in the antenatal period followed by the iron therapy may reduce the subsequent need for the blood transfusion. Okay, we should try to reduce the need of the subsequent blood transfusion. If after careful consideration elective transfusion is required, women should be fully concerned about the potential risk, and the written information should be provided, and valid informed consent should be obtained before transfusion is administered. How should women who decline blood transfusion be managed? It should be optimized prior to delivery to prevent avoidable anemia, and consent refusal of the blood and components and other transfusion sparing techniques should be discussed and documented during antenatal period. Use of the pharmacological, mechanical, and surgical procedures to avert the use of the bank blood and the blood component should be considered early. Now, intraoperative cell salvage has a role in the management of patients who refuse allogenic blood transfusion. Okay, now one thing is about the optimization of the HbA before delivery and its importance is written here. There are additional challenges in the management of pregnancy in the woman refusing blood transfusion, including for the religious purpose, for example, Jehovah's Witness, with a high risk of morbidity or mortality. Accordingly, all the women declining blood transfusion require careful multidisciplinary planning with a senior clinician input during pregnancy to minimize anemia and to manage blood loss. Early use of the iron supplementation is indicated with, if needed, use of the intravenous iron. Okay, antenatal planning is essential and hematinic deficiencies should be corrected if HB is less than 105 gram per liter for all women before delivery. Use of the blood component and other sparing technique that is written here. The training clinician will need to establish which blood component or blood sparing techniques, for example, clotting product, are acceptable. Okay, an example of suggested care plan for managing women refusing blood transfusion is available here. Okay, so leave it. Consent. The importance of consent is written here. The woman should have an opportunity to discuss the consent alone, witness with an experienced clinician. Treating clinician should ensure that woman is fully informed of the risk of refusing blood transfusion and maternal mortality data for Jehovah's Witness compared with the non-Jehovah's Witness, and this needs to be handled sensitively to avoid any possibility of coercion. Okay, and an advanced directive should be completed and carried out in the handheld notes. Although the women should always be given opportunity to change their mind about the use of the blood products. Now the importance of the wristband is written. The woman will wish to wear a no blood wristband to make it clear to all the members of the treating team that the blood transfusion is not to be used. Now something is written about the patient blood management. The use of the patient blood management program is recommended by AABB, formerly the American Association of the Blood Bank, the Australian National Blood Authority, and the National Blood Transfusion Committee, which covers England and North Wales. And PBM involves all encompassing approach to avoid unnecessary transfusion by optimizing preoperative pre-delivery HV, avoiding over transfusion, using cell salvage where appropriate, accepting evidence-based low transfusion triggers, and using intravenous or oral iron supplements in the women who are not actively bleeding and are cardiovascularly stable. Okay, so this is all about the guideline of the blood transfusion RCOG guideline. Thank you so much for your patience.